to Modern Orthopaedics. On today's episode, we are here with Jeff Neumann. He's CEO and founder of North Texas Medical Research Institute here in the North Texas region. And so welcome, Jeff. Welcome to the podcast.
Thank you for having me.
Tell us about NTMRI. What is it? Why did you start it? How did you start it? And what's it all about?
Yeah, so Dr. Bernie and I are always looking for ways to make what we do better here at OSD. And so I've had research background before in the past. Prior to getting into PA school, did clinical research over at the medical school here in Dallas. And I've been a part of a lot of research studies from then and always had an inkling to be able to do that for people to kind of help progress medicine and be a part of that cutting edge. Dr. Bernie is kind of the same way. And so when I came on board, in addition to being a PA, him and I have talked about, kind of where we can go further from here and how we can make this practice better. And so that was basically the impetus of us being able to birth the NTMRI, North Texas Medical Research Institute. And so him and I together, along with a close friend, Kelly Payette, were able to kind of start this group up. And I've been the CEO since, along with lead coordinator, and just trying to see if we can push medicine further, and not just with OSD, but just kind of across the board.
When did NTMRI start?
Started in kind of middle to late 2021.
2021.
So not a group that's been around for a long time, but at the same time, we've done a lot in this last year and a half to 2 years.
So before we get into kind of what y'all do with regards to research, explain research. So if I'm a patient, what does research mean?
Sure. Research is basically just a way for us as clinicians, but also just generally speaking as scientists, to be able to kind of figure out how we can make things better. And that's kind of a very simplistic way of putting it, but that's really what we do. And so we use that using trial and error. So if you go back to the old grade school, talking about trial and error and kind of how we go about making experiments, this is obviously a little bit different than that, but kind of the same pathway. So with clinical research, what that means is that we're using, not in a lab anywhere, we're actually using research participants or real humans and people to figure out how we can do things better. A lot of these studies that we do are already FDA approved, and we're just trying to figure out maybe one thing can be better in a different way, either a product or a surgical technique or a particular medicine. We try to figure out what ways can be better with those things.
So you do have FDA backing. So it's not like you're just saying, we're going to try this on patient A and just see if it works.
Most of the time, yes, but there's actually a study that we are doing currently that is not FDA approved. It is approved in the European Union. And so there's also a lot of studies that do get started in the United States that they have to start somewhere. And so they'll have a new technique, a new medicine that's coming out. And so the FDA is part of that process to make sure that it's safe and effective, and they have different ways of going about to making sure that's done. It usually takes not just a week or two to get these things approved. Usually it takes months to years to get these things approved. And they need people to be able to participate to see how well they react and how they don't react. And that's where we come in as a way to help get those studies facilitated and get that data in so that the FDA can show whether this is safe and effective.
Explain to me from a consumer standpoint how I get involved if I have interest, or how I even find out about research.
Yeah, there's a lot of different ways of doing that. Sometimes it's where we as the Clinical Research Institute actually come to you because, for instance, there's some studies that I look at that I try to fit the right patient for this particular clinical trial, which is just, again, another way of saying a research experiment is clinical trial. So we'll try to find a patient that meets this age group, this type of knee problem, and then I'll approach them and say, hey, you're doing great, but at the same time, we have this research study that you would be perfect for. Are you interested in it? And so I'll broach that subject with patients and kind of talk them through that and see if they do have any questions or concerns. And then if they fit the mold and they agree to participate, then we can keep going from there. Other times, we'll actually put out advertisements either on the airwaves or on public television or on the internet, a lot of social media, obviously everyone in social media, podcasts and all these other things. We'll put those things out there to where we'll just put something out and see who responds back. So again, it can be a two-way relationship. So we'll try to see if we can find people, but then also too, we put things out there so people can find us.
Now, are yours primarily orthopedic based?
Most of the stuff that we do here for NTMRI with OSD is orthopedic based and musculoskeletal based. It doesn't mean that you have to have only a bad knee or bad hip to participate. We do other things that are for younger patients. We're looking at different studies right now to get into that have to do with sports injuries. A lot of it is orthopedic based because basically that's what Dr. Bernie and I know. That's our bread and butter. But our research institute was founded on the idea of not just helping orthopedic patients. So we are planning on expanding that out. And we're also going to try to work with other institutions and other groups to see if we can go into non-orthopedic areas as well.
So tell me a little bit about the research y'all are doing now.
So currently we have a few studies on board right now. We've already completed one with Johnson & Johnson last year using a different device inside the OR.
Can you talk about your research? If it's not published, can you talk about it?
So there's some things I can talk about on it, but there's some things that I can't because it isn't published yet. But this device is already publicly used, so it's not anything abnormal. But yes, there are some things that, again, that's part of the research decorum, so to speak, that you have to you can't spill the beans on things that haven't been published yet. But this particular device is called the Concise device. So it's basically like an automated hammer that we use inside the OR. The old school days, and really still going on now, is fancy carpentry. So we use a lot of chisels, we use a lot of mallets, and Dr. Burney also uses those chisels and mallets. And so that ends up being a lot of strain on the surgeon to use those devices day in and day out. So there's companies out there, including Johnson & Johnson, that are looking at ways of making that easier for the surgeon. So they have basically just like a power tool version of things. And so they want to try that out to make sure, again, it's safe and effective. It's already FDA approved. It's been out for a while. And they are marketing it, but they're trying to gather more data.
If you would go to a patient, approach them and say, are you good with us utilizing this tool in the OR? Okay.
Yep. And every research study that we do, and this goes with either FDA approved or not, we have a certain level that we have to abide by, and we can't do anything unless we get consent from the patient. So I'm going to approach every patient ahead of time before anything is done. That includes any surveys, anything. So by law, I cannot do any research study on patients unless there's something going on. There's a small exception to that, which I was part of a research study a long time ago where there is emergency research done because it's hard to consent people during an emergency. But again, that's extremely, extremely rare.
Tell me some of your other research projects.
Yeah, so that was the one completed one. We're currently under 3 studies right now. One with Smith & Nephew looking at a different type of device that uses hot water instead of straight electricity, which sounds barbaric. And a lot of stuff we do in the OR is probably pretty barbaric. But so there's a device that we use now that has less tissue damage for people getting hip replacements. So they have good blood control, better tissue healing. And so the idea is that they recover faster. So we're investigating that device right now with that company.
Is it a tool that cuts? Does the incision?
Cut.
No.
Nope. It actually uses hot water to scald those tissues that are bleeding.
Got it. Okay.
So that way, as we're going through the tissues into the hip joint, we're able to have good blood control, less tissue damage, and people go forward. At least that's what the company's idea is, and that's why we test that out to see, does it really do that or not? So we're about 50 patients in right now to 75, so we're hoping to complete that here in the next couple months. So that's one study. The other study I had alluded to before was the non-FDA approved study. We're the only site in the state of Texas right now that is doing this. So there are probably about 8 sites across the United States. They're trying to get approval in the United States. The company's name is EpiSurf. It's a Swedish company. They have a device called the EpiSealer knee, which is a completely customized piece of metal basically that goes in, and I call it fills the pothole of the knee. So if you think about a road, when you have a road, you don't necessarily need to replace the whole road if you have a pothole or two. So the idea is you replace just the pothole and not the entire road. And that's what this device does. There's a lot of patients that are starting off in their journey and kind of in the orthopedic world where they come in, they have knee pain, and we've already done a knee scope with them. They're doing okay, but they still have some pain, and they do have kind of these potholes in their cartilage. They're not bad enough for a knee replacement. So they're kind of in this purgatory where we try these other things that are non-operative, including injections, therapies, medications. But they're getting better. They're doing great, but not 100%. And so we're basically waiting for some of these patients to get bad enough to get the knee replacement, because we can do another knee scope, but it doesn't always justify it and sometimes kicks the can down the road, so to speak. So this device is basically made for that. It's completely customized. It's MRI derived. So in other words, they do an MRI. They'll actually make the tools, the device, everything is customized for that patient. And because it's non-FDA approved, the entire study is basically covered by the sponsor. So we'll actually have the patient come in. There's a lot of consent that goes into that because it's not FDA approved. But they're able to get the device, they're able to get the procedure, the anesthesia, all that is covered by the sponsor. Again, it kind of has some nuances to it. So that's the EpiSurf device. And then the final study that we're a part of right now, those are the two studies that we're on right now, the Smith & Nephew and then EpiSurf. We've already completed the third one. And then we're also in talks right now with a couple of companies, including Zimmer Biomet, and then looking at other devices that track motion post-operatively, and then us be able to communicate through smart devices. So we can actually track a person's knee replacement, how well they're doing at home. So I can see how much they bend, how much they extend, how much they walk, if they have a fall, all through my smartphone. And then they can communicate to me and I can communicate to them. The idea is that we can track people a little bit better. We can see how well they progress, but then also too, if something is starting to happen where they're starting to plateau or decline, we can see that and kind of encourage them to go forward or see if there's something wrong. So it's a kind of a more intuitive AI-based, but also technology-based thing that we can use to kind of help make sure that we get these patients moving forward. So we're trying to be on the cutting edge of a lot of different things. We're looking at other investigative studies as well. I try to create some of my own studies with different devices. We try to do our own things here. So again, we're always looking at different things to research and make things better.
If somebody's interested in one of these studies, do they contact you?
They can, absolutely. They can reach me on my website. They can also reach me by phone. They can call me, they can text me, they can do everything they want to do. I usually have a phone number attached that's research only. So that way they can contact me 24/7, basically, much to my wife's chagrin.
Is there any incentive for them to do research? Like if I was like, hey, I want to try this, am I incentivized as a patient?
Yes and no. So I think as far as how they're incentivized is twofold. One, of course, everyone thinks when they thinks that they're getting incentivized, they're getting paid. And yes, there are studies that do that. For instance, the non-FDA approved one, we actually pay people to come to see us. So we'll give them a gift card and then they'll get paid for the research study itself. There's other studies where they don't get paid, but we don't charge them extra for anything research related. That's the Smith & Nephew study. So they would still have their normal surgery. They would get charged with anything standard of care, which is standard of care. But anything research related, they're not going to get charged for. So it's nothing extra. They do have to invest time into it, but at the same time, they're not going to get charged extra. So that's the money portion of things. Now, there's other parts into it too, where it plays into kind of the moral and ethical part of it too, because we need people to help us make things better. And so then there's that moral and ethical obligation that sometimes people feel that they feel like, okay, I can help people get better by giving my time and my effort and my knee pain to make people better too down the road that don't have to experience this. So again, it's kind of a twofold thing between the finances as well as also just that inner need to be able to help people.
So what's your vision?
Oh, my vision.
With research.
Yeah. So my vision with research is, again, to kind of push this idea of making us better. And not just the OSD, even though Dr. Bernie and I are both two entities in one, right? It's because we're OSD as well as NTMRI. The whole goal is to help out our patients. We want to make sure that we're a part of that process because we've been clinicians for a long time. We have that knowledge in there, but we also know that there's so much more that we can do and do better for our patients. And so we hope to be a part of that process.
So you want to improve outcomes?
Absolutely.
Awesome.
And then we're always looking for new ways to make things better. So again, if people have any ideas, if they want to participate, I'm more than happy to answer any questions or concerns they might have.
I think just with research, like you can change the pathway of healthcare. Truly. We've talked a lot about being outcomes driven, and I would like to change this organization to more of an outcomes driven. Obviously we have good outcomes, but how can we make them better? And I think you hit the nail on the head. Like we can't do that if we don't have people willing to kind of break the barrier and break the mold and try a new technique or a new tool that will help patients in the future get better outcomes. So
as far as data, our data now, and you can see this with anything, not just research, you can take yourself anywhere. You can go out to the mall, you're looking at Facebook, whatever. The phones, the data, everything is tracked real time. There's all this data. Think of like a huge bin of everything in it. So that's constantly being collected all the time. Some of it's junk, some of it's not, but we don't know that until we actually go in and dive in and start organizing it and kind of seeing what comes out of it. So, and that's the way we feel about with our EMR systems or medical records and the devices that we use. I think we actually underutilize a lot of these tools in data analytics. I'm actually I'm kind of nerding out a little bit on data analytics. I'm taking classes on it too to see how I can make myself better at being that data analyst. But this is where I think a lot of research studies can be born and also ideas on how we can make ourselves better, because we don't know some of the things we don't know. For instance, like we're talking about the Who's and Who's study, which is a survey in how people are doing in their daily lives with their knee pain before surgery as well as after surgery, so I can track that. And before, we weren't really doing anything with that data. We're collecting it, but we're not doing anything with it. So maybe we're missing the point sometimes where maybe a patient's having trouble running after surgery or whatever reason, which they're not supposed to run a whole lot after surgery. But still, maybe there's something that is affecting their daily lives that's across the board for our patients that we just didn't know until we actually started looking at the data. And again, that's where I think that data analytics and looking at all these points that come in from everywhere is super important. Not just from a clinical research standpoint, but also just from me as a PA taking care of my patients. I want to know, like, hey, these are the pitfalls that you're going to run into afterwards. This is the things to look out for. I'm basically their guide. And so that way they know how they're going to go through things. A lot of the companies that I speak with are on that same pathway. Zimmer Biomet, Stryker, a lot of the big names in orthopedics, they're tapping into that data and they're trying to collect it and make algorithms. One of the things that I heard about, which is kind of, it seems like a pipe dream, but it's not that far away, is say we collect all this data and now we know. I go up to Jane Doe and I say, you fit this mold, this is your criteria, this is what medical morbidities you have or medical comorbidities that you have. This is the type of knee that we're going to do based on the data that we have. Because we've done an algorithm, we've done 1,000 patients, and this is the best thing to do for you based on the data. We've done it so far. A lot of the stuff we've done historically has been, well, this is kind of what I felt like. This is what's best for you. And sometimes we had to have journal articles and everything to publish that and back that up. And that's been how medicine has been done for a long time, which is honestly has been fine. But at the same time, we could do better. And that's where I think these data analytics comes into a huge play. Again, I could go on for another hour on talking about data analytics. And a lot of the companies and everywhere else across the board are really starting to tap into that idea.
So how are you going to actually use data? I think in healthcare, we get all this data and then we don't do anything with it.
Exactly. And that's what I was alluding to before, is that I think we collect a lot, but we don't do anything with it. We don't have any outcome data to show for it. And I think we can generate research studies based on that to make ourselves better. We can look at how we're treating our patients, not only that from a clinician standpoint, also from a payer standpoint. So I can now go and look at our data and I can tell you that Dr. Burney does a really good knee and hip and a shoulder. But it's not just me telling you that. I have data to back that up now. I can show you that based on the national average, Dr. Burney does better job on his Who's and Who's surveys afterwards compared to anyone else that's done a national average. And that's
patient's experience.
Exactly. That's not us telling that. That's the patients telling us that.
So like a patient satisfaction survey.
It can be considered that, yeah.
What about, does that play into infection rate or readmission rate or revision rate?
Absolutely.
So he is way above the national average with outcomes.
That's what I've seen so far.
Okay.
And we're collecting that data to confirm that with other people. But again, we don't just tell that to patients. We tell that to our community. Mm-hmm. We tell that to our community leaders. We tell that to the primary cares that are sending us patients. Like, hey, you can feel comfortable knowing that we have the data now to back that up and we're going to take care of your patients.
Where I see it making a big impact is population health. So if we could take it from a surgical realm to a patient realm and say, Jeff, you're a young middle-aged man with kids, you don't smoke, but maybe you have a drink every now and then, you're going to fit in this bucket and we know how to conservatively treat you to keep you out of the healthcare system. So I think that that's where data is huge in healthcare and we underutilize it. So research is a big part of that.
Absolutely. And not just from making people feel better, it saves people money too, and the system money. I know we don't like to talk about money in healthcare sometimes too, but we have to, especially with the way the economy is and everything else. If we can show a better way of doing things that makes people better and saves the institutions money, saves people money in their pockets too, then everyone's happy.
Y'all have a patient, I won't say their name, and she can't afford her knee after she found out she had to pay for therapy. And so secretly, your boss doesn't know this. I'm he's created a bundled package before. Why are we not giving her a bundled package? So I really am secretly going to try to make that initiative and then give it to you and him and say, listen, because she can't afford it. She doesn't have insurance. She's not going to get insurance. That's her demographic. She's going to have to at some point pay for it or go outside of the country to get it. So how do we keep her in these walls? But anyway. That's
a good
just
question.
a side note, but that would be, I mean, I think that's like, how do we integrate research into bundled payments? You know, like bundled payments. So like I can go to Madison and I are physical therapists. We know that if you have a total hip, chances are you don't need more than 4 visits post-operatively. We can treat you, we can manage you, and probably in 5 years you won't need any therapy. But like from a research standpoint, how do we integrate research and bundled payments to give patients like the best outcomes?
It's data all the way, and data and outcomes.
So preoperative data. So like looking at my medical history, my activity level.
I think you look at the whole realm. You don't look at just one silo. You can take that into consideration. So for instance, we look at their preoperative data and see what they feel like they can do and not do based on the objective measures that we take. So what I mean by that is we send people off for prehabilitation. So in other words, we're going to test them to see how strong they are. So we can kind of see, you know what, you're not that strong yet. We need to work on some exercises. These are the pitfalls you're going to have afterwards. Again, being a huge guide. And then also making sure that, you know, we're telling patients and educating them, because this is the things that we need to personalize medicine for, and we can do that with data. And also too, in the preoperative realm, I've re-engineered a score based on a journal article that I saw. I know it sounds very nerdy. Yeah, it is. Trust me. But one of the scoring systems actually takes their entire medical history. It puts a number to everything that they have, including the medications that they have. So this is the aura score that I was talking about before. So it's based on that system, but I modified it a little bit to make it more us. And so far it's been pretty accurate. So basically I can give a patient a number based on their medical history and their medications that they take, and they're smoking, not smoking. And I can tell you with a high certainty that this patient is going to need readmission, or this patient's going to need a hospital stay, or not need readmission, but they have a higher chance. So then I can categorize these patients better. I can say this one is okay for the surgery center where they don't have patients that are stay overnight. This patient is probably better served to go to a hospital. Even though they'll be discharged most likely the same day, at least I know that if we need to keep them overnight because they're higher risk, I can go ahead and do that. So
I'm going to challenge you. If you have the person that needs to stay overnight because they're high risk, are you, right now the way we manage them is we put them in a different level of institution, right? They're going into the healthcare system with the hospital. Is there any way to proactively manage them so they can get into like a day procedure, an ambulatory surgery center? Like, would you ever tell me, you know, Lauren, you're overweight and you're smoking. So my initial suggestion to you before we replace your knee is I need you to, you know, lose weight or, you know, stop smoking. Are those conversations you have?
Absolutely. Day in and day out. But I also know that it's a struggle. I don't know about you, but during Christmas time, I go ham on those cookies. And so I'll go anything. So it's just hard to really just kind of, you know, we can talk about those things. And so, but at the same time, I feel the struggle that the patients struggle. You know, I'm not in their shoes. I can't tell you exactly what they're going through, but I can tell you that with 100% certainty that we can talk about these things, and people do try, but sometimes they have shortfalls because we're all human. So same thing with like weight loss. Like one of the things I'll tell patients is that, you know, every pound that you lose is 3 pounds of pressure on your knee. So if you lose 10 pounds, you're actually losing 30 pounds of pressure on your knee. But also too, know that, you know, it's a struggle out there. If you look at, like, I take my kids out to go grocery shopping, and just to buy like a healthy meal to put together yourself takes time, effort, and then money, versus going down to McDonald's or Brahms. I can get a bag of 5 burgers for $5. So, I mean, just the economics alone is something to look at. And also too, smoking, for instance, is really hard to quit. It's a legal drug that's out there and people use it all the time and have been for years. There's a study out there, I remember this from PA school, and it's actually harder to quit smoking than it is cocaine. Just because of how prevalent it is. And so again, that's a struggle. So I can try to educate people, which they're usually receptive to this. It's just hard to change, and it's hard to make them then go to that lower level so that way they can be in there. So what we try to do then is just to be smart and know that, you know, they're human. They try to do what they can, and we try to manage those things a little bit better. So if we can, what we call optimize the patient, then what that means is we try to get their blood sugars down. We try to help them with smoking cessation, at least for 30 to 60 days. We try to talk to them about weight loss, try to get them in a medical nutritionist. So that way they become a better patient. And we can try to do that. But again, it's kind of it's a two-way street between us and the patient. And we know that it's hard to do.
Is there anything that would disqualify me from surgical intervention?
Yes. So there are hard and fast rules, especially because we know based on the data that if we have a patient that has uncontrolled diabetes, their hemoglobin A1C, which is a measure of how long they control their blood sugars over a course of 2 or 3 months, not just something like at a day-to-day finger stick, because that's real time. But if their hemoglobin A1C is extremely elevated, usually you try to keep it between 5 and 7. If it's like 9, 10, 11, that tells me that the patient has not, unfortunately, done very well in controlling their diabetes and that they're a huge risk for infection and complications after surgery. So in which case then we tell them, I'm sorry, we can't do surgery yet until we fix this. So there are hard and fast rules for sure. NTMRI was born out of the idea of helping our patients and working together with OSD. I think that there's a good synergistic relationship, not just because Dr. Burney and I are both clinicians as well as research personnel, but we want to make things better across the board. They can always reach out and touch base with me on the website. They can try to call me. They can try to email me. Again, I'm open and just here to help.
Okay. Well, thank you, Jeff, for your time today. It's been definitely a pleasure talking to you and learning more about research. If people listening want to go to your website, we'll put the website display below, and then they can call you personally and ask questions.
Sounds great.
Thank you.
Thank you, guys.